السؤال عشان نشوف الكاميرا شغالة ولا لا. الكاميرا شغالة ولا لا. Can you hear us? Okay. أنا ما تقدر تشوف بعد.
All right. Thank you. All right, Assalamu alaikum, everybody. Okay. I can start without.
Yeah, I can start.
All right. I guess I don't need to touch any of that. All right, so we'll continue with the same modality, starting with case number 2. This is where we arrived last time. So I discussed with you earlier the hyperplasia. And I told you that actually for the tissue to respond in hyperplasia, it has to be able to divide, right? So then there are tissues that are faced actually with stressors that are not able to divide. So how will it respond to the stress or to the stimulus? And that's actually where the second form of adaptation takes place. So who's going to read this? Any takers? Okay, go ahead, please.
60-year-old man with
complaints of
severe shortness of breath and peripheral edema. Past history of a heart murmur that was diagnosed 10 years ago during an employment physical. No follow-up care has been given for this murmur. Labs, chest X-ray revealed significant cardiac enlargement and course in the hospital. He sustained a cardiac arrest shortly after admission and could not be resuscitated.
All right. So what do you think happened in this case? How did it come to happen? So they are telling you that 10 years ago, the guy actually came in with a heart murmur, but it was not treated, right? So it followed up with absolutely nothing. There is no follow-up care. And then eventually he showed up in the emergency room with shortness of breath and peripheral edema. And if you actually look at the autopsy findings, you're going to be seeing an enlarged heart, what we call cardiomegaly, with thickened ventricular walls. And the aortic valve was calcified and showed stenosis. You guys have taken actually a little bit of CVP in year 1, right? Do you recall what is the most common cause of aortic stenosis? Well, it is one of the causes of aortic stenosis. No, it's not hypertension. Of cardiomegaly, it is hypertension, absolutely, because it's going to play a role similar to aortic stenosis, but aortic stenosis itself. How about in the whole world? In general, it is actually rheumatic fever. All right, so rheumatic fever causes inflammation. And then eventually this inflammation is going to be fibrosed and is going eventually at later stages become calcific. That's actually why, valves involved in patients with rheumatic fever get stenosed. But actually that is in the most of the world. In the US and in the West in general, it is going to be usually a degenerative kind of disease. So disease as a result, usually of old age, as a result of multiple factors, including, hypercholesterolemia, hypertension, the whole 9 yards. All right, but that's not what we are discussing here. What we are discussing here is how did this patient end up actually with, the findings that he has and why actually he eventually died as a result of these findings. In pathology, it is the science of comparison. So in order to figure out exactly what is happening, you need to compare the findings that you have in autopsy or in surgical pathology with the normal. And in this case, this is exactly what you are doing. Can you see this? Can you see the guys in home? I mean, they cannot hear me, right? They're actually the last time the arrow was slightly yellow, right? Anyone knows how to do that?
I mean, the pointer.
Yeah, the pointer, yeah, because they would not see my pointer and they wanted me to point with this. Right click, and then pointer options. Wow. And then you can pick and choose, right? All right, how about laser pointer? If I can manage to do it. All right. Okay, that's it. Thank you. All right, so on the right of your screen is actually a normal heart. The measurement of a normal left ventricle thickness is about 1.2 to 1.5 centimeter. Now, if you compare that to the left ventricle here, you can see the difference, right? It is much more than that. This is almost 3.5, probably even 4 centimeter. You see that? Okay. So what happened when you have this kind of thickness actually in the myocardium? Before that, how did it end up actually doing this in this patient? Go ahead.
There's been a change in the stress the cardiac muscle cells have been exposed to. So they have to undergo hypertrophy since they're permanent tissue.
Right.
And they couldn't undergo hyperplasia.
Right.
So just
Very
because
good.
of hypertrophy alone, the ventricular wall increased in size.
Excellent. Very good. This is exactly what happened. It was faced with an obstruction to the flow of blood, right? The obstruction in the left ventricle, in this case, it is in the form of aortic stenosis. This is what we found on the autopsy, right? So what happened here is that, as a result of this stenosis, the left ventricle was facing a what you call a gradient in the pressure, a pressure gradient, against which it had to actually contract much more forcefully. And as a result of this, over a good period of time, over a long time of 10 years, eventually ended up actually causing, enlargement of those cardiac muscles. And, what you see here in the form of cardiomegaly. So what happened actually? Why did this guy die actually in the first place? Let's go back to see how he came in. Shortness of breath and peripheral edema, and then eventually cardiac arrest. That was not able to be treated, and the guy died. So how did this happen? When you have this much thickness of the myocardium, the blood supply usually that supplies the myocardium comes from the outside in, right? This is actually in the form of coronary that goes on the surface of the heart. And in this case, in the case of the normal myocardium, you can see actually that those coronaries have about 1.3 centimeter to cross to supply the most, distal part of the myocardium. What happens actually when you have about 3.5 to 4 centimeter in terms of thickness to that supply of blood? Most likely it will not actually reach for two reasons. One, it is very distant from the origin, which is on the surface, right? So the areas that are most likely to be affected with that are going to be the areas just beneath the endocardium. This area is right here, because it is the most distal from the surface. That's number one. Number two is the fact actually that you have so much muscle mass. What will happen to those poor, perforating arteries that are trying to supply the myocardium? They will collapse as a result of so much mass, right? So the end result is going to be ischemia, further ischemia. And as a result of that, those patients will die. Now, before actually this affects the myocardium, what are, those muscles that are going to be affected with, with the ischemia before the myocardium? So let's say, actually you have done, and this patient comes in and they tell you actually just, that he died as a result of myocardial ischemia, okay? Or myocardial, whatever they call it, it is actually acute coronary syndrome. There are many names for the same thing. But you open actually the heart and you look for a scar on the, on the myocardial tissue, and you don't find that. How did this guy die actually in the first place? Any idea? Go ahead.
Maybe because he has heart failure, he went to pulmonary failure.
The lungs will not kill you unless it's COVID-19, right? Yeah, but this is not, actually, this is a joke. Yeah, no, it's not going to kill you. Usually, that's going to happen when you have so much heart failure that will be coupled with lung, pulmonary failure. That's what you call cardiopulmonary, failure that resulted in this patient's demise. But no, that's not the reason for this. So the cells that are going to be affected earlier than the myocardial cells are going to be the neural cells, right? They are going to be the conduction system that is in the heart. What will that result in? When those cells actually suffer ischemia, what will that result in? Sorry? What do you call fibrillation or a flutter or, a block? Sorry? Exactly, arrhythmia. That's exactly what's going to result in that patient's demise. So as a result of the arrhythmia, there will be what you call ineffective left ventricular function, right? That's what you really care about. It is the left ventricle because that's where the myocardial mass is the most, so the end result is going to be death as a result of the ischemia that this patient has suffered from. But that's beside the point. So here actually what you have this aortic stenosis that has been actually, staring at the heart in the face, right? Telling it you have to overcome me in order to, to pump the blood into the left ventricle. Eventually, that results in actually this kind of appearance, which is cardiomegaly. Now, what will happen if this actually, let's say that the patient did not die, and the patient actually managed, patients manage to live with incredible conditions, for extra amount of time. So let's say that this guy actually lived long enough to not die as a result of this. What will happen to the heart muscle eventually? So you have cardiomegaly. Let's say that this guy actually lived another, let's say 8 years. How will he die, 8 years from that, point in time? So 18 years from the discovery of the valvular defect. Eventually, actually, what you're going to find is that those cardiac muscles, that are enlarged will simply wither away. They will, at one point in time, they will start to die out. And instead of the cardiomegaly, you will see cardiac dilatation. Okay, that's what they call a floppy heart eventually. So as a result of that, there will be also no contractility, but that's later on, much later on in the course of the disease of this patient. That's going to result from a phenomenon known as cardiac remodeling. Again, beside the point, but just to give you the full story. Now, if you take a section of a normal myocardium right here and you compare it to an enlarged myocardium, you can see that it is very striking, right? So if you look at the size of the myocardial fibers, you will see that it is much larger in this with the cardiomegaly. You look also at the nuclei, and you will see that it is also larger, a testament to the fact that those cells have actually undergone cardiomegaly and have added more proteins and myofilaments to the cytoplasm in these cells. All right, so this is simply what happened in the case of hypertrophy. So in this case, actually, those cells are not able to respond with hyperplasia. So the way for them to respond to this, process is going to be in the form of hypertrophy, getting larger in size. And how does it do that? That's actually what we're going to be talking about. So, but before that, there are actually causes of this, including increased workload, as you can see here. That actually is going to be seen with the skeletal muscle for someone, who goes to the gym and starts to work out, weight training. Also with the left ventricle, the same exact effect of aortic stenosis will be seen also with hypertension and other diseases as well, that is going to obstruct the flow of the blood from the left ventricle. For example, coarctation of the aorta. For example, if you have, any kind of increased thickness in the left ventricular wall, that is going also to result in similar presentation. All right, and then also in uterus, but in the uterus, you will see it is not just hyperplasia, it's not just hypertrophy, but also hyperplasia. So two things are going actually to result in the increased size of the gravid uterus. Removal of an organ, you take out one of the kidneys, you will see that the second kidney that is left in, will actually increase in size One of the way for it to happen is, through hypertrophy, and in this case also hyperplasia. So hypertrophy and hyperplasia are known to happen together in certain tissues. How does it happen? So when you are pressing against that poor cell, what's going to happen is that that poor cell is going to actually make up, or respond by the making actually of what you call trophic and stretch triggers. That's going to be in the form of soluble substances. Those soluble substances include growth factors, include special forms of mediators, messengers, if you will, that are going to go after certain genes or certain actually conduction pathways. And they are going to activate those conduction pathways. The end result of these conduction pathways will be the making of more myofilaments and more structural proteins that are going to add to the size of the cell. So in that case, the cell is going to respond with much more vigorous kind of contraction. So it's adding these proteins because that's going to help it actually to contract stronger. So that's one way for the hypertrophy to happen actually in these patients, the patients with cardiac problem, cardiac hypertrophy. The other way for that to happen is a switch actually in the myocardial fiber. That's happened also as a result of this obstruction. A switch from the the alpha form of myosin heavy chain to the beta myosin heavy chain that is known actually to be thicker, and that is known to contract stronger than the alpha form of the myosin heavy chain. So two ways for that to happen. One, through actually a conduction pathway or conduction pathways that will result in the making of proteins and myofilaments. And the second one is going to be a switch of the myosin heavy chain, a change of the myocardial fibers itself into a beta form of the myosin heavy chain that will have a thicker and also will contract much more forcefully than the alpha form. Examples of hypertrophy, we saw the cardiac hypertrophy. This is, I think by now is clear. And then you have the gravid uterus, and compared to the normal uterus, as you can see here, I mean the distinction is very clear. It is much more larger. That's what you call actually abdominal uterus, usually during the late second and third trimester of pregnancy. If you take a section, it happens, for example, that this female did not survive for whatever reason, and if you take a section of this gravid uterus, you will see that the size of the fibers are going to be also distinctive between the normal uterus and the gravid uterus. Here, the fibers are much smaller, much thinner, and the nuclei are much more spindly. That's what you see with smooth muscle cells. But compare that actually to what you find here, you're going to find actually a more plumpier cell, a more rounder cell, if you will. And the nuclei are larger than what you see in the normal uterus. Here's another example of that, what you see in iodine deficiency. One of you last week asked me, how does iodine deficiency result in goiter? Actually, for two reasons. One, let me tell you that the goiter that is happening in those patients happen not as a result of only hypertrophy, but also hyperplasia. So there are two actually adaptation mechanisms that so far that went into play to result in this appearance in this patient. But in the case of iodine deficiency, which is needed to produce the T3 and T4 hormones, what's going to happen to the response, the feedback response from the pituitary gland? The pituitary gland will start actually to make more TSH, right? More thyroid stimulating factor that will go and work on the thyrocyte, on the thyroid cells, to increase, to crank up the production of thyroid hormones, right? In the process of doing so, it will increase the size, and also it will put these cells in a hyperplastic state, if you will, that is going to give rise to this appearance. One of the examples we talked about last week was actually autoimmune antibodies, right? Autoantibodies. That is a cause of goiter. And I mentioned to you that the same process could be actually causing both, hyperthyroidism and hypothyroidism. And that is going to be in the case of the hyperthyroidism, such as Graves' disease, what you call autoantibodies that are actually of the stimulatory type, right? And then there are other antibodies of the inhibitory type, what you call inhibitory autoantibody or inhibitory autoantibodies, such as what you see in where? In Hashimoto's. Both of them will result actually in the appearance of goiter, right? A lot of times, actually, as I mentioned to you, that there are families where you see the same conditions run in different members of the family. Sometimes the same patient may actually start with one and end up in the second state later on in life. Again, beside the point, but just to add a little bit to this presentation. All right, so iodine deficiency and goiter. So you can see how hormones actually play a role in this. All right, so now we're going to be talking about atrophy. In this case, actually, instead of going large in terms of hypertrophy or going many in terms of hyperplasia, the cell will realize that the best way actually to adapt to the ongoing, new state, if you will, is going to be actually by simply, scaling down. Scaling down, there are many names for it. It will simply, become a smaller version of itself. So let's say that there is one organ where there is an interruption of blood supply, okay? If the cell actually is going to keep on, at the same size that it was on when, the blood supply was ample, the cell will simply die because there is not enough actually oxygen that will come to sustain that cell's life. So the end result is going to be that this cell is going to actually, make itself a smaller version of itself. It's going to go down in size. And it does that by actually shedding, compartments from the cell, shedding elements from the cell. And when it becomes a smaller version of itself, so this mediocre amount of blood supply that is coming to it is going to be enough to sustain it and to actually keep it alive. All right. So shrinkage of cell, that's what you see in life as well. Let's say that someone, was actually having a big company, right? And this company has a lot of orders. All of a sudden, the company lost all the orders as a result of the COVID-19 disaster, right? So there's two ways, for that to be solved. One of them is going to be to close down the company. The other way is actually to simply make it a smaller, version of itself. So instead of dealing with like 100 products, let's deal with 5 products and see where that will take me. Why does he do that? Because that is going to result in decreased expenditure. He will not need as much money to run his company. He will not need as much people to run his company. And as a result of that, survival is going to be the answer to this solution. All right, so those cells actually, as a result of the fact that they are shedding compartments from themselves, usually you will see them almost in a form of a state of hibernation. So they are not dead completely. They still have some functions, but they are still alive. So let's say that you actually return the blood supply to that tissue. Those cells will be able actually to come back from their state. So it's a wait and see kind of state, waiting for the right condition to set in to go back to normal. All right, so how does that happen? A couple of ways for that to happen. I mentioned to you blood supply. There are other ways for that to happen, including, for example, if you have interruption of the innervation. If you have, for example, interruption of movement, let's say that you put a limb in a cast and you forget about it for a couple of months, 3 to 4 months. The end result is going to be that the muscles of that limb are going to become atrophic. This is why they tell you early ambulation is always important. Trying to move actually, whatever organ that has been injured or damaged, as soon as possible after that injury and after the recovery is going to be of paramount. The reason for this is that blood supply is going to return with ample amount to the site of injury. This is one. 2, innervation, the innervation and the stimulation through the nerves in that region is going also to happen when you have early ambulation. So a couple of ways for that to happen. So you may see it in physiologic conditions, such as what happened in early development. This is one of the conditions that you see that has really what you call an intricate relationship with apoptosis. So atrophy is actually what you call it a hibernation state. It may go all the way to actually keeping the cell or killing the cell completely. So that is going to be seen in early life. There are many anatomic actually structures that the human being is born with that are not going to be actually sustained later on in life. They are going to disappear. Could you give me an example of that? Any structures that were in the fetal life that eventually are going to close down, if you will? Right, but that's probably an extreme form of what do you call that? Sclerodactyly? Is it sclerodactyly? Not sclerodactyly, no. I forgot the name of that, but I know what you're talking about. How about or the urachus, for example? The urachus, right? That is going to be this fistulous communication between the bladder and the umbilicus, right? This is one. Any other thing that is going to be even a better example of that? Ductus arteriosus, right? This is also this communication between the two, great vessels of the heart, between the aorta and the pulmonary artery. What happens to it after life? After birth, I'm sorry, after birth, or in the late stages of pregnancy, and that's going to close down, right? Because at that stage, at one point in time, there will be a reversal of the flow of the blood, and as a result of the increased O2 content, what will happen to that ductus arteriosus? It will shut down. How does it shut down? How does it disappear? There are a couple of ways for the cell to die. Only a couple of ways, two ways really. One of them is going to be necrosis, and the second one is apoptosis. Which one happens here in this case? Apoptosis, exactly. Apoptosis is the physiologic way. Apoptosis, if you think about it, is an extreme form of atrophy, if you will. It is the end stage of atrophy, of non-resolved atrophy, if you will. Did you guys get it? So if you think like, let's talk about a spectrum. Atrophy is here, and apoptosis is to the right of it. It will go all the way to killing that cell, simply, the organ disappearing in this process. Okay? That's what you see with physiologic kind of atrophy during the early development. You can see that also after delivery, after pregnancy, with the involution of the uterus. Usually the uterus, you have seen actually the picture here, will go back to almost normal. It will never go back to how small it was before pregnancy, but it will shed a lot of actually its size, eventually going back to what we call, almost semi-normal, size and shape. Also in the process of atrophy. Now, pathologic conditions, there's, a lot of conditions that may result in the same kind of presentation. For example, if, as I mentioned to you, if you cast a limb, that is going to result in that. And I mentioned to you why, because there is going to be less blood that is flowing to the side because the muscles are no longer working. And also there is less, muscle, workout. And also at the same time, the nerves are no longer actually, supplying, in terms of like a daily kind of motion. They are not as active as it used to be before. And the result of that is going to be atrophic, muscle fibers in that organ that has been casted. Loss of innervation, you see that also, in certain neurologic conditions such as poliomyelitis as a result of the loss of lower motor neurons. You have a reduced blood supply. You can see that in many actually places, including, for example, the cerebral, hemispheres in a patient with, carotid artery atherosclerosis. That is going to result in decreased mass in the cerebral hemispheres, resulting in what's known as cerebral atrophy. You may see that also resulting actually from renal artery atherosclerosis. There's a good example of that here. That is going to result also in the atrophic, appearance of the kidney affected with this condition. If you actually decrease the supply of protein, such as what you see in cases of malnutrition, that is going also to result in the same kind of presentation. Here's an example. It's a poorly done example, I think. Here, you will see it better here than in the. So if you look actually in your laptop, you will realize that this kidney right here is smaller than this kidney right here. The reason for this is that the ostium of the renal artery here is open, whereas in this one here, it is closed by an atherosclerotic plaque that affected actually the amount of blood supply that is going to that kidney. Here's an example of that, much better example of that, where you see the cortical atrophy has set in, and the corticomedullary junction is blunted in some way, and also there is expansion of the medullary fat, as you can see here. So two examples of the atrophy that follows that follows atherosclerotic disease and reduced blood supply. Decreased hormonal stimulation, for example, that happens when you have hypopituitarism. All the organs that are connected to the pituitary gland, if that pituitary gland, suffered from, a condition that resulted in decreased actually production of the hormones, will result actually in atrophy in those end organs. Could you give me examples of conditions that may result in hypopituitarism? You guys have just done the endoripro, right? So any example of conditions? Go ahead.
Sheehan syndrome.
Sheehan syndrome, resulting from what?
From hemorrhage that leads to less blood supply to the pituitary gland.
All right, so that's going to result actually in infarction, right? To those cells that are present in the anterior pituitary. Any other example? Good example, thank you. Go ahead.
Maybe a tumor.
Exactly, a tumor that is growing in the anterior pituitary that is going to overtake, right? It's going to compress so much. So it will result in two kinds of actually atrophy: atrophy to nearby cells that are not actually, part of the tumor cells, right? So to nearby cells in the pituitary itself, and then because it is killing those nearby cells, those hormones that are produced by these nearby cells are going to be decreased also in amounts, and the result of that is that the end organs that depend on those hormones are going to also suffer atrophy as well. All right, there are many examples, as you can see here. Here's an example. Let's say that you are actually you're giving someone, a TSH. You're giving someone a T4, T3 or T4. In this case, actually, resulting. This is actually You're giving them a T4. Right? The name of that actually is going to be synthroid. Is it synthroid? Have you guys taken any pharmacology in Doripro? What's the name of the T4? The pharmacological name. I used to remember it. Anyway, so actually, you're giving this hormone because those patients are hypothyroidic patients, right? What is that going to result? What is that going to do to the TSH itself? So this is exogenous T4, right? What will it do to the TSH? It will knock it down, right? So it will go and it will oppose the production of further TSH from where? From the pituitary itself. What will that result in the thyroid gland itself? As a result of that, you will see that the thyroid gland will decrease in size because the TSH have been knocked down, and as a result of that, there is no longer actually the hormone that is going to sustain, the size or the number of and the shape of those thyrocytes. So the end result is going to be thyroid gland atrophy. You see it with aging. Part of aging is going to be actually, is going to be decreasing in size. That's in a way actually also is connected to, the atherosclerotic disease that you see in multiple arteries. But also, independent of that, you may see that, aging itself may result in this as well. So independent of any kind of interruption of blood supply. Increased pressure, for example, patients with cystic fibrosis known actually to have very thickened kind of secretions. What is going to happen is that as a result of this, all the secretions that go through the ducts, wherever it is in the body, are going to be so thickened that it's going to result in obstruction of the flow of the secretions of those ducts. Example of that, what you see in the pancreatic duct. and the result actually of the expansion of the pancreatic duct with this very thickened, inspissated, obstructed, secretions is going to be the expansion of this pancreatic duct and the atrophy of the cells on all sides of this pancreatic duct. Another good example of that is what you see when there is compression by a tumor. Another example of that, if you say, that, for example, that someone has a diaphragmatic hernia, and as a result, congenital diaphragmatic hernia, and the baby end up actually with abdominal organs in the chest. What will that do to the lungs? The lungs are going to become atrophic. Why? As a result of the compression by the nearby, organs. Many examples of that. Let's say that someone actually is really old. Number one. Number two, actually, he's having some serious, atherosclerotic disease in the lower abdominal aorta. That is going to, follow also into the iliac vessels. What will that result in? When you examine the testicle of that patient, the testes of those patients are going to be small. This is going to result in a testicular atrophy as a result of the interruption of the blood supply. Here is an example of adrenal atrophy that is going to be associated with the empty sella turica syndrome. What's the empty sella turica syndrome, you guys? You have just finished endoretro, right? Go ahead. There's no pituitary, right? This is a pretty ambiguous name. I think a funny name, really, if you think about it. Empty sella turica, that you looked for the pituitary and it was not there. It was not in the sella turica where it usually resides. And the reason for this could be resulting from many actually causes. One of them is infarction, as we have talked about. So as a result of that, all the organs connected to this pituitary are going to become atrophic. Example of that is what you see with adrenal atrophy. Here's the example of cerebral atrophy right here. So this is in a normal brain, in a normal cerebral hemispheres, where you see that the gyri as ample, A-M-P-L-E, and the sulci are actually shallow. Now, if you look here, the gyri becomes thinner and the sulci becomes deeper because of the loss of brain material, okay? So that could be, one of the causes, but it's not really that. It will not be as bad as it looks here, is what you find, for example, in aging. It will be much lighter than that, but also as a result, definitely, of an atherosclerotic disease in the bilateral carotid arteries, okay? So how does atrophy come to happen? There's a couple of ways for that to happen. One of them is that, the minute that there is interruption of the nutrient or the blood supply to that cell, you will see that there is going to be activation of a special enzyme known as the ubiquitin ligases. So the ubiquitin ligases are going to actually go and tag, if you will, or mark, the compartments of the cell that are going to be targeted by degradation. They are going to tag it with multiple copies of the small peptide ubiquitin. And the end is history, because once that happens, then those compartments are going to be degraded mainly by the ubiquitin proteasome pathway. So that's one way for that to happen. The other way for that to happen actually is going to be what you call the process of autophagy. If you think about it, it is really the cell eating its own to survive, okay? And in this case, it will not go through the proteasomic pathway, rather it will go through the lysosomic pathway. So in this case, those compartments are going to be joining up, fusing up with the primary lysosome, and that's where the degradation will take place. The end result is going to be that the cell will scale down its size because it has lost compartments from its size and has become a smaller version of itself. All right? Are we okay? All right. So one of the products of this degradation is going to be some of the leftover fat that is going to be known actually as lipofuscin, also known as the tear and wear pigment. One of the characteristics place to find it in the body is going to be in the seminal vesicle. If you cut a seminal vesicle, you will see a lot of golden brown kind of pigment that is actually the lipofuscin. If it before that, if it accumulated enough in an organ, if there is extensive kind of atrophy in an organ, and there's so much of this lipofuscin that has accumulated in that organ, it will give it a very brownish color. That's what we call brown atrophy. This is where it comes from. Here's an example of that. You see that? All of that actually is lipofuscin, but in this case, it is in liver cells. All right, so now metaplasia. This is what you call the monster in the, the elephant sitting in the room. This is what going to be a last resort, if you will. If you recall, we talked about what happened, when a bronchial cell faces, the good stuff that they put in the tobacco. For your information, probably it's a good, public health message to you, because a lot of you are contemplating, to smoke or not to smoke. Don't smoke. Here's a good public health message to you. Don't smoke. In the cigarette that a person smokes, there is actually 70 different carcinogens and toxins, including radioactive isotope. That's quite a statement, actually. They put radioactive material in your cigarettes. It's incredible, if you ask me, but this is what they do. Now, when those poor cells in the bronchi face this kind of toxins and carcinogens coming their way, how will they respond? The first way that they respond, it's a labile tissue, right? It's a tissue that is always in a state of regeneration. And what's going to happen is that first is going to produce many of the same. So instead of a couple of layers of the epithelium, it will produce much more than that. So there is going to be thickness of the epithelium, of the bronchial epithelium. That's not going to work. So then it will actually start to become, larger than itself, and will produce much more amounts of mucus, trying to ameliorate, trying to lessen the effects of these toxins on the bronchial wall. Also, that's not going to affect. Eventually, what's going to happen is that it will resort to, as I mentioned to you, reinventing itself. It will go back to the drawing board, if you will, to the stem cells of that tissue, and it will make it go through a different line of differentiation, knowing fully, this is incredible, knowing fully that the other type of cell will be able to withstand the toxins better than the original tissue. So in the case of the bronchial epithelium, it will go back actually, and instead of going through the columnar, differentiation route, it will take actually the squamous route. The reason for this is that squamous cells are rounder, are smaller cells. Their cytoplasm is much more sturdy. It's tougher than actually what you see in the plumpier columnar cell that is present originally. So the end result is going to be a switch of heart, if you will, a switch in the basal cell layer, in the stem cell layer. Eventually, that is going to give rise to a different line of cells that will be able to deal with the ensuing, injury to that tissue better than the original cells that were there. In the process of doing so, so there is a survival issue here, right? Great. So the cell was able to survive under a different name, if you will, right? Like imagine someone actually who have done, usually this is what they do, someone have done something bad, they go and reinvent themselves. They move into a different city, they take a new name. You cannot happen in many parts of the world. I'm telling you what happened usually in the US, taking a different name, taking a different job, if you will, a different personality for all I know. The end result is going to be able to actually withstand the new circumstances. But in the process of doing so, it will lose some very critical kind of criteria that used to be there in the original tissue. For example, the columnar tissue has cilia, and the cilia are very critical actually to the function of the pulmonary. Those very tiny, if you think about it, brushes really, if you think about it, are very critical to the normal function of the respiratory system as a whole. And why is it important? Because these cilia have this, outward motion. They work at first as a trap of anything that is coming in. So this cilia is covered by mucus, right? And the mucus acts as a trap of whatever that is coming into the airway. And then with this, with this motion that it is having, is going to push it out of, the airways into the mouth and outside the body. When that is lost, when the cilia is lost as a result of the squamous metaplasia that happened, what will happen to those bacteria and viruses and everything that comes in, but does not find the mucus, but does not find actually, it will no longer find this kind of ciliary motion that is going to spit it out, right? The end result is going to be what, in your opinion? Infections, exactly. Infections. And if you start to have repeated infections over a good period of time, what will that result in? What do you call that? Repeated infections within 3 months. You will see that actually when you go into clinical medicine. If you see like so many cases of inflammation that results from this process, that's what you call a chronic bronchitis, right? Eventually, that may result in what is known as a COPD, chronic obstructive pulmonary disease. Now, chronic bronchitis could actually be a harbinger eventually for the development of tumors, okay? And that's exactly, where the link between squamous metaplasia and tumor development happens. So the theory is that during the exposure to the toxins and the eventual actually squamous metaplastic process that happens in multiple regions, throughout the pulmonary system, because that's what you call a field effect. This smoking is affecting pretty much the whole, pulmonary bed, right? The end and the bronchial bed, and the result of that is going to be what? One of those foci may actually undergo so much inflammation. With time, it may result in neoplastic transformation and the development of cancer. This is where the link happens between cancer and metaplasia, okay? All right, so we did talk about this. The early stages of this process is reversible, even probably the intermediate stages. But if you let it go for a while, let's say someone who has been smoking 30, 40 years, then there's all bets are off, and there's very likelihood that those metaplastic foci are going to actually turn into a real, a cancer at that stage. All right, so we did talk about the survival advantage and the fact that important protective mechanisms are lost. All right, so here's an example of that. Look at the normal columnar cell here. You can see the cilia right there at the top, and you can see the amount of cytoplasm that is far more than what you see in the metaplastic cell. The metaplastic cell, the cytoplasm of the metaplastic cell is tougher. The cell itself, its rounder shape makes it able to actually take care of whatever comes its way than this plumpier, more fluffy kind of cell. There are many types of metaplasia, so it is not just, squamous metaplasia. Let's say that actually this is happening, there is an inflammation in the urinary bladder. What happens in the urinary bladder? Here's another example of squamous metaplasia in the urinary bladder. What kind of epithelium you have in the urinary bladder? Urothelium, right? Transitional epithelium. So let's say that actually there are, eggs of a special parasitic infection known as schistosoma that becomes embedded in the urinary bladder wall. What will that result in the urinary bladder wall? Inflammation of?
The formation of columnar epithelium.
Not columnar. So what's going to happen, as a result of this actually embedding of the eggs of this parasite, that is endemic in some areas of the world, you will see that there's going to be chronic inflammation in the urinary bladder wall. With progression, with a chronic kind of state, the end result is going to be the appearance of a tumor. The kind of metaplasia that will happen will be from urothelial tissue into squamous tissue again. How about actually if someone is having, is binging at night, and then actually, trying to sleep, and he's feeling all this acid reflux over an extended period, over years, let's say 5, 6 years. What will that result in the lower esophagus? So the acid is going all the way up, right, into the lower esophagus. What is the color? Go ahead.
This time it's columnar.
Exactly. In this case, intestinal. So what happened actually, because again, it's like you have to think about the cell as a living entity. It knows exactly what happens. The cell knows actually that the cells of the stomach are more able to withstand the acid, right? So when the cells of the lower esophagus are facing actually the acid reflux, it decides to go the stomach way. So it undergoes what is known as a goblet cell metaplasia, intestinal cell metaplasia, and also Paneth cell metaplasia to result in the formation of what is known as the Barrett esophagus. So if you look at the lower esophagus in this case, you will actually figure that you are in the GI, in the stomach or in the intestine, rather than in the lower esophagus where you see the squamous metaplasia. So again, it depends on what is the best way to deal with the ongoing injury. In this case, it is going to be a kind of actually intestinal goblet Paneth cell metaplasia, all right, known as Barrett's esophagus. So you may see that in different ways, in different places in the body. Wherever that happens, I did mention to you the schistosomal infection. There are other actually examples of that pretty much everywhere in the body where you see this kind of transformation. Now, the squamous metaplasia is probably the most common form of metaplasia in the body. So what you see here, you see a replacement of whatever tissue with squamous tissue. Example of that, what you see in the bronchial epithelium, you see it also with the HPV infection, human papillomaviral infection. You may see it with the schistosomal infection, the schistosomal hematobium infection. You may see it in the corneal epithelium with vitamin A deficiency. So it depends on the condition. The end result is going to be a switch from the original epithelium to a squamous epithelium that will be able to take it much better than that. Now look at this. You can see actually that the change is happening starting with the lower layer of the epithelium, right? In the basal cell layer of the epithelium. That's usually where the basal, or the stem cells reside, from which, it gives rise to the squamous metaplasia. So the switch does not happen in the already differentiated cells. That does not happen, what you call a cross differentiation or a trans differentiation. It cannot happen. It has to happen from the stem cell layer onward. Here's an example of that with HPV, human papillomaviral infection, and you start to see, the glandular epithelium right here, but then all of a sudden you start to actually figure out that there is a switch to squamous epithelium as a result of the ensuing, infection with the virus. Here's another example of that, where you see the schistosomal eggs that get embedded in the lamina propria here. And as a result of that, there is a very brisk kind of chronic inflammation. All those dark dots are actually chronic lymphocytes. So lymphocytes that are present in the blood, in the urinary bladder wall, that eventually is going to result in transformation of the normal urothelium, the transitional epithelium, into a squamous, tissue, as you can see here. All right. Here's another example of a squamous metaplasia that happened at the level of the renal pelvis. The renal pelvis lining is urothelial lining, similar to the ureter, similar to the urinary bladder. And if there is actually irritation as a result of the presence of a stone in the pelvis, the end result is going to be also the change from the transitional epithelium, the urothelium, into the squamous epithelium. A very nice actually picture showing you, the transition from the urothelium to the squamous epithelium here. Here's another example of that. That's actually at the level of the lower esophagus, what is known as Barrett's esophagus. As a result, first of reflux that is happening over a long period of time. The first effect is going to be reflux esophagitis. Eventually, you will see that this reflux is no longer to happen, is no longer to actually be dealing only with the squamous metaplasia at the level of the lower esophagus. That epithelium is going to again change hard and goes into columnar epithelium, knowing fully well that this is actually the best way to deal with the incoming acid, with the acid that is getting up into the lower esophagus. These cells, you see these cells with the gaps here, what looks like a gap. That's what you call the goblet cells. Okay, Nearby are the intestinal cells. So it's a couple of forms of metaplasia that will make up this Barrett's esophagus. One of them is goblet cell metaplasia. The second one is intestinal cell metaplasia, and the third one is Paneth cell metaplasia, neuroendocrine cell metaplasia. Okay. And how does it do it? It happens actually at the level, again, of the basal cell layer, of the stem cell layer. It does not happen in the differentiated line. So reprogramming of the stem cells to give rise to a completely different line of tissue that will be able to withstand the ensuing insult or injury to that tissue. All right, that's it. All right, any questions? Sure. Chat. All right. I don't know what to get out of this. Thank God for you guys. Yeah. Yes. Yes, there's a question here for us. Tafadhali. Since I put my mask, I cannot even hear, not just talk. Tell me what is it? Hypertrophy and cancer. I like it. Yeah. I'm sure you will probably, if you open a book, if you open like PubMed, you may see something about that. But no, it's not. Hyperplasia, yes, absolutely. Hyperplasia and cancer, you go hand in hand. Hypertrophy and cancer, no. Atrophy and cancer, also no. Metaplasia and cancer, absolutely yes. So probably the worst when it comes to cancer risk is going to be metaplasia. All right. What's up?
Other questions, doctor. So what are the three
Right. So this is actually the when it comes to Barrett's esophagus, this is some of the it depends really like who actually you're talking to. Like some pathologists, look for the goblet cell metaplasia. The minute they see it, they call it Barrett's esophagus. Now, some other pathologists who are probably a little bit more into this topic, more specialized, if you will, look for three types of metaplasia to call Barrett's esophagus. And if one is missing, they call it incomplete Barrett. So they call this is not really for you, but I think I mentioned it just for the sake of completeness. So they call it actually goblet cell metaplasia is one, intestinal cell metaplasia is second, and thirdly it is Paneth cell metaplasia. So they have to see the three to call it Barrett's esophagus. Right. So metaplasia and cancer. So at one point in time, you will see that those cells that are actually, you have to realize that metaplasia will happen in the in the mix of chronic inflammation. Actually, the metaplasia itself will happen as a result of chronic inflammation in pretty much everywhere, with the exception of probably vitamin deficiency, as we have seen here. So the end result is going to be that chronic inflammation is a pre-neoplastic state, okay? And as a result of that, cancer is likely to arise from metaplastic foci because of their, relationship with chronic inflammation.
I read the book that atrophy can include both decrease in size and number. How about the permanent?
Sure, decreased size and number, absolutely. How about permanent tissue? Well, I mean, well, this is exactly what I said, that atrophy is a spectrum. There is atrophy of scale down in size, and then there is eventually, if it goes all the way to the right, you will see complete loss of tissue, right? So in a way, it is a spectrum. So yes, absolutely, decrease in size and number. When the cell is lost, it's dead, right? And that's what you see with apoptosis. So if you think about it, as I mentioned to you, that apoptosis is or has a very intricate relationship with atrophy. If you think about it also, you may call it actually the most extreme form of atrophy, if you will.
And he did the size before this.
Before this. Which one? This one here? This one here.
Yes.
Yeah? All right, so what happened actually? So first, there's going to be, let's say that you are actually having increased reflux into the lower esophagus. That happens from a couple of reasons. The most important actually reason why this may happen is a LES defect, lower esophageal sphincter defect. The reason for this is that it could be actually resulting from the fact that there is increased abdominal pressure. For example, for someone who's having constipation, for women who have actually pregnancy. So the presence of this gravid uterus in the abdomen, what will it cause to the pressure in the abdomen? It will increase it, right? So you have to think about the GI also as a single tube. So if you have an obstruction, with let's say with there is actually obstruction of whatever kind, if that is going to. I'm trying to to remember the name, the English name for that. If you bear with me for 1 second. Constipation. If you have constipation in the lower, in the lower part of the GI, what will happen to the pressure in the upper part of the GI? It's going to build up, right? And that's going to reflect actually back into the stomach and into the lower esophagus, taking with it the acid that is going to come into contact with the lower esophagus, resulting in this, heartburn that you hear about. So the first actually appearance, of this acid in the lower esophagus is going to, if it happens severely over a good period of time, but shorter period of time, let's say a couple of months, you will have what is known as a reflux esophagitis, okay? Simply inflammation, chemical inflammation, if you really think about it, resulting from the, I'm having heartburn now, okay? So, so resulting from the fact that this acid is coming in contact with the lower, squamous epithelium. If this goes on for an extended period of time, untreated, what is going to happen is that this, lower squamous epithelium will decide to go the actually glandular way, because it realizes that the glandular way, the glandular epithelium, is much more able to deal with this reflux than the squamous epithelium. Where does it take this clue from? It takes these clues from how the stomach itself deals with the acid, right? So the way it does it is that it will reprogram the stem cells, usually present in the lower, in the lower part of the epithelium here. Okay, it will reprogram it to produce not squamous cell, rather glandular cell, as you can see here. All of this are glandular tissue that does not belong to the lower esophagus. And the lower esophagus have, taken it up in order to be able to withstand the acid. That's what is known as the Barrett's esophagus.
Is liver fibrosis a type of metaplasia?
No, liver fibrosis is a type of injury, actually. It is a type of repair, if you will. So it's not a type of metaplasia. The liver cells will not, transform into a fibrous cell. No.
Is necrosis the most extreme form of pathologic atrophy?
No, apoptosis is the most extreme form of pathologic atrophy.
Barrett's esophagus is squamous or columnar?
It is columnar metaplasia. Barrett's esophagus is columnar metaplasia.
That's it.
All right, thank you.
Thank you.
And how do you close this, by the way? Thank you very much.
But I need to.
Oh, sorry.